I'll just start with this picture of our brand new hospital that is currently under construction, and it will be a state-of-art facility both for clinical work as well as research. We do carry a lot of endometriosis research in Aberdeen. So I've been asked to talk about endometriosis and fertility. Sorry, I can't seem to move my screen. I'm just trying to be so I'll try this way, maybe that'll work. Right, there we go. So we all know about endometriosis. It is a long-term condition estimated to affect about 1 in 10 girls and women. But actually, the true prevalence of the condition is unknown. The two hallmark symptoms of endometriosis are pain and infertility. And endometriosis actually causes a huge healthcare as well as socioeconomic burden to the society. The direct and indirect costs, which includes healthcare costs, time off work, loss of work productivity, is similar to many other long-term conditions, such as Crohn's disease, rheumatoid arthritis, and type 2 diabetes. But the resources allocated to endometriosis are much less than any of these conditions. As we know, the gold standard for diagnosis of endometriosis is a keyhole surgery, though in some cases you can actually diagnose a chocolate cyst or endometriosis in the ovary by ultrasound scan, or by MRI you can see deep endometriosis. But generally, for the vast majority of women, it is laparoscopy. So endometriosis is actually quite a complex condition. It is a very enigmatic disease. It occurs in various forms. The most common one is what we call superficial peritoneal. The reason we call it superficial is because it's a bit like a rash on the lining inside the tummy, generally in the pelvis. It can occur in various forms. The lesions can be blue in color, red, white. We also have deep endometriosis. The deep endometriosis is a bit like nodules, which sends kind of roots inside. It can affect the ovary, forming cysts filled with chocolate-colored fluid, which is known as chocolate cysts. It can involve bowel, and there can be disease outside the pelvis as well, such as involving lungs, diaphragms, or scars. Example, cesarean section scars. There are several theories of origin of endometriosis, and we don't fully understand them. But there's also an impact of environmental and genetic factors. Women whose first-degree relative, that is mom and sister, have endometriosis are 6 times more likely to have endometriosis compared to those who do not have family history of endometriosis. Similarly, there are various classifications of how to class endometriosis. The most common one is ASRM, which classes endometriosis as grade 1 to 4, that is minimal, mild, moderate, and severe. However, none of these classification correlates very well with the symptoms, especially pain, though we can predict fertility outcomes slightly better. And we all know that there is asymptomatic endometriosis, when it's a chance finding doing some other operation or doing a scan or something else. So moving on. Well, I'm not even going to mention adenomyosis here. So this is another benign condition where cells from the lining of the womb are present in the muscle wall of the womb, while in endometriosis, the cells from the lining of the womb are present outside the womb. Adenomyosis can occur in up to 30 to 70% of women with endometriosis and causes symptoms very similar to endometriosis, such as heavy and painful periods, as well as painful intercourse. And this can further complicate the management of those who have endometriosis. So I'm going to start with a picture of what a normal looking pelvis is. As you can see in the middle, this is the uterus. These are the fallopian tubes, and these are ovaries, the white ones. And this is bowel coming at the back. So this is a picture of a normal pelvis when we do a laparoscopy. In endometriosis, things can look very, very different. You can see there are a lot of more blood vessels. There are endometriosis lesions, which can can be red in color, they can be blue and black in color, they can be fibrosis, and adhesions or scar tissue, which causes organs to stick together, is often seen in endometriosis. The ovaries can have cysts, they are enlarged, they are often stuck to each other, commonly known as kissing ovaries, and sometimes stuck to the back of the uterus. The uterus also looks slightly bulky, so potentially could have coexisting adenomyosis. So this is what endometriosis looks like. I mean, there are also many other forms you can see, but this is slightly more severe kind of endometriosis. So let's look at endometriosis and reproductive function. We know that endometriosis impacts almost every aspect of a woman's reproductive cycle. It can affect the egg quality, even for naturally produced eggs. We also know that the actual endometrium, which is the lining of the womb, is different in women with endometriosis compared to those who do not have endometriosis, which means there can be interference with implantation, and it is very well established that it is a pro-inflammatory condition. So there's increased inflammation within the pelvis, within the lining of the womb. And all these things can affect reproductive function, fertility, and even pregnancy, which I will explain in a little bit more detail as we go along. So talking about endometriosis and infertility, the true prevalence of the condition, as I said, is still unknown. So the data we have is from various studies. If we investigate subfertile women, about 25 to 50% of subfertile women will have endometriosis. The rates are much higher if there is concomitant period pain along with subfertility. It is estimated that in those with infertility, endometriosis is 6 to 8 times higher compared to fertile women. But if we flip it the other way around, about 30 to 50% of those who are diagnosed with endometriosis may have subfertility. Subfertility does not equate to being not having children at all. We know that in the long run, up to 80% of women with endometriosis can have children, either naturally or with some help. For the 20% who didn't have children, it is difficult to know if they didn't want to have children or were they not able to have. So we don't have that data. Obviously, there are significant variations over age. So the older the women are, the higher the chances of subfertility with endometriosis. So this is just a graph showing the natural live birth rates in untreated couples. So unexplained infertility is the one where we don't find any cause for fertility. So all the checks, both in the male partner and the woman, are fine. There's approximately 30 to 40% chance of naturally having a baby. If you have early stages of endometriosis, that is minimal or mild endometriosis, it is expected to range between 10 to 35%. But moderate to severe endometriosis has a huge impact on fertility, and it is expected to be less than 10% chance of naturally conceiving. But this can be overcome with some medical help. So let's look at the potential mechanism for infertility. So there are various proposed theories. There's this pelvic factor. As I showed in one of my previous slides, there can be adhesions. These adhesions can involve the tube and the ovary, which can actually impede the release of egg from the ovary and how the tube picks up that egg and the transport into the uterus. So this is usually seen in moderate to severe endometriosis. So there is almost a degree of tubal blockage due to distortion of anatomy. The other things which are common in endometriosis is some hormonal imbalance. So we know that endometriosis is a very estrogen-dependent condition, and it exhibits resistance to another hormone known as progesterone. And this is commonly seen in endometriosis cells. This hormonal imbalance can result in infertility and also sometimes in carrying of pregnancy. We talked about inflammation. It is well established that endometriosis is an inflammatory condition. there's higher concentration of inflammatory cells and enzymes within the pelvis, which can impact the function of the egg or the sperm or fallopian tube. The mechanism is not quite fully understood. There's a lot of research going on in it, but we still don't have answers. And lastly, the environment inside the lining of the womb is altered, which can impede implantation. It can either lead to subfertility or increased risk of miscarriage. So how can we treat subfertility associated with endometriosis? And often we talk about three things: medical treatment, surgery, or medically assisted reproduction. Unfortunately, with the endometriosis, any medical treatment which is hormonal in nature doesn't allow women to get pregnant, so medical treatment is hardly used when it comes to infertility. However, the jury is still out in terms of surgery or assisted reproduction, which is generally IVF. It depends on a number of factors: whether women have concomitant pain, how old they are, what stage of endometriosis it is, duration of fertility, and other factors such as if there is coexistent male infertility as well. So talking about surgical treatment, the most common surgical treatment is done keyhole, laparoscopically. It is either ablation, where the surgeon burns away the various lesions of endometriosis, or excision, where you cut away and you can send it for pathology, excision of endometriosis. Ablation and excision can be done for peritoneal endometriosis, but for deep endometriosis, it is excision only, because burning does not impact the deeper endometriosis. There is some data that the natural conception and live birth rates are improved after surgical treatment of endometriosis. There's also an added advantage of surgical treatment, which includes improvement in pain symptoms. So these days, the common principle is see and treat. So women undergoing laparoscopy, if endometriosis is seen and if it ranges from minimal, mild, or moderate, it is generally treated at the same time. But if it is severe, such as involving the bowel or other organs, a second stage surgery or referral to tertiary care center would be required. Sometimes in advanced endometriosis, surgery is needed to release ovaries so that they are accessible to get the eggs and facilitate IVF. So generally speaking, the improvement in fertility is more so in earlier stages of endometriosis rather than advanced stages after surgery. Now, there's often a debate which patients are likely to benefit from ART and which are the ones who should naturally try after surgery. And there's a classification or a score known as Endometriosis Fertility Index, which helps to predict natural pregnancy rates after surgery. This is a composite of score based on patient factors such as age, duration of subfertility, and if somebody has had a previous pregnancy. The surgical factors are taken into consideration are function of tubes and ovaries, the extent of lesions of endometriosis, and the staging of endometriosis, which is stage 1, 2, 3, 4, that is minimal, mild, moderate, or severe. The score ranges from 0 to 10. The higher the score, the higher is the chance of natural conception. Generally speaking, if it's between 7 to 10, the chances of conceiving naturally are high. But if it's less than 7, women are likely to benefit from IVF. So assisted reproduction, there are two techniques which are commonly used. One is intrauterine insemination, where the sperm is injected into the uterus at the time of ovulation. We would normally offer up to 6 cycles of intrauterine insemination, and it is found to increase pregnancy rates in stage 1 and 2, and could be considered in stage 3 and 4, though it's not as effective. The gold standard for any kind of subfertility, whether it is endometriosis related, whether it is due to the tubes or due to ovulation issues, is actually IVF. And it's usually done in advanced stages of endometriosis where there is a compromise in the tubal function. So the journey doesn't end here. Endometriosis can also affect pregnancy. As a part of my PhD, I looked at data of all new women diagnosed with endometriosis in Scotland over a 30-year period and evaluated their pregnancy outcomes. We found that there's a slightly increased risk of miscarriage, ectopic pregnancy in women with endometriosis. And those who go beyond the first trimester, there's a slightly higher risk of low-lying placenta that can cause bleeding during pregnancy or preterm delivery. However, the antenatal care and early pregnancy units in the UK are very good, that these problems are likely to be detected timely, and intervention can be done in a timely fashion for safety of mom and the baby. So I also wanted to talk about our Aberdeen Centre for Women's Health Research. We have a life course approach towards women's health, and we do all kinds of research ranging from subfertility, pregnancy, menstrual health problems. We undertake clinical trials. We also engage with specialties outside the ONG. We look at various study designs and are also exploring novel methods for treatment of various conditions. Some of the most advanced trials in endometriosis are actually running from Aberdeen. So currently there are 4 trials in Aberdeen running in the UK, 3 of which are led by Aberdeen. We also have qualitative studies, health economics, and patients' perspectives. We have a very strong PPI input from Endometriosis UK, and we are very grateful to them for that. Right. So lastly, I would like to share the Scotland peer support groups, as well as a WhatsApp group, which is for women with endometriosis and subfertility. So thank you for listening. I'm happy to take any questions.
Thank you very much, Lucky. It was very, very good. I've got some questions here that have been sent over. I'll just
let me just stop sharing my screen. And I'm sorry if there was a lot of medical stuff, but I can probably clarify those when people have questions.
Brilliant. I've got some questions here. So the first one is, how much is your ovarian reserve likely to be impacted by surgery to remove an endometrioma?
So that's a really good question. So any surgery on the ovary can impact ovarian reserve, but more so for surgery for endometrioma. This is just the way endometriomas are almost stuck to the lining of the ovary. This is a very tricky situation, and we were wanting to do a trial to see whether women should go straight for IVF in presence of ovarian endometrioma, or whether the endometrioma should be removed and then they should have IVF. So we don't have answers of how much it is impacted, but it is impacted. Equally, the stimulation can be affected if there is an ovarian endometrioma. So we sometimes have to remove the cyst to facilitate ovarian stimulation. And we try to be very careful to prevent any damage to the ovary, but this is microscopic damage. You can't see with naked eye. But it can't be quantified, and it's very variable. Having said that, ovarian reserve can already be low in women with endometriosis, and they poorly respond to stimulation during IVF, even if they don't have endometrioma. So that's another complicating factor. Age is the single most important determinant. So the younger the women, the higher is the likelihood of getting good quality eggs and less damage to ovarian reserve. But the older the woman, especially over 35, it becomes exceedingly difficult.
Fantastic, thank you. And the next question is, after 3 failed ICSI transfers with good blastocysts, will a laparoscopy to remove a 5 centimeter endometrioma and pelvic scarring improve my chances of conceiving?
So that's a very tricky one. It's as I alluded earlier in my presentation, that there is evidence that if we treat minimal and mild endometriosis, there's improved fertility and pregnancy rate, but it's not as much for moderate to severe endometriosis. So if there is an endometrioma, it's already an indication that it's moderate endometriosis. It may also be complicated by other factors. So if there are 3 ICSIs which have not worked, it is very difficult to say that removing the endometrioma alone might help. And each woman actually needs a bespoke package of care, so we don't have to take several factors into account. So one thing alone does not help with pregnancy. So I think it needs a specialist input, I would say.
Brilliant, thank you. And the next one is, if left ovaries are adhered to the bowel, is it still possible to conceive naturally?
Yes, it is. So we all read about the miracle stories, and women have 2 ovaries. Usually they would ovulate in one cycle from one ovary and another cycle from another ovary, though not necessarily alternate. So you could ovulate twice from the same ovary for consecutive cycles. So as long as the other side is not affected, people can still get pregnant. And even if it is stuck, if the tube is in a position that it can pick up the released egg, pregnancy is possible. Obviously, it can take longer, but it's not impossible.
Brilliant. The next one is, I just had surgery and I have been trying for a baby. I am going to be referred to the fertility clinic by my gynaecologist. When should I start treatment and what are my options?
So it'll depend on a number of factors. When we talk about fertility, we want to do investigations on both the female and the male partner so that you'll be treated as a couple. Usually, women are referred after a year of trying, but those who have advanced endometriosis or those who are older than 35 years of age, they are referred within 6 months of trying if they're not pregnant naturally. And your best treatment will be worked out in discussion. It could be either IVF or IUI, depending on the stage of endometriosis and other factors involved.
Brilliant, thank you. And the next one is, I've just been diagnosed with adenomyosis after years of suspecting I could have endometriosis. This journey has been going on since 2015, possibly earlier, as I was told I had IBS about a decade before that. As part of my journey, I read a book called The Period Repair Manual in June 2019. It mentioned an endometriosis trial that was carried out in Italy in 2013, including a drug called NAC. So my very long, drawn-out question is about whether anyone has heard if there is any plans to adopt this kind of treatment in the UK for adenomyosis and endometriosis sufferers. It would be nice to see something that is much less invasive and still has good results.
So there are a lot of trials going on in the UK for treatment of endometriosis, both from Edinburgh and Aberdeen, but not with this particular drug. Most of these are surgical trials, so they are aimed at superficial endometriosis, deep endometriosis, and also at recurrence of endometriosis. There was a small study on dichloroacetate, which is a drug used for other purposes to try and endometriosis. But at the moment, the drug mentioned is not licensed within the UK. There are some things are just within the trial setting, and it would depend on the results of a multi-center large trial before something is available routinely or another trial here. But they're very, the rules for trials are much stricter in the UK compared to what can be done in Italy or China and many other places in the world. So it has to be very evidence-based and, most importantly, safe for the patients.
Fantastic, thank you. That's the questions that we had emailed over. Now we've got some that come over tonight. So the next one is, does having PCOS as well as endometriosis impact the chances of conception?
So this is like a two-edged sword. Both of them can independently affect fertility. PCOS usually is related with ovulation issues, and endometriosis affects fertility in a number of different ways, which I discussed in my presentation. So yes, it can affect fertility. The one positive thing about PCOS is the number of follicles is high. So the problem which we see in women with endometriosis, that we get very few eggs, is not there if PCOS is there. So that may be a silver lining. But again, I would say that it requires specialist input. And if not naturally pregnant within a year, or depending on the age, it could be 6 months, should get referred to fertility.
Super, thank you. The next one then is, do you have any lifestyle options that might help reduce symptoms and or increase fertility, such as diet, exercise?
So there's a lot of anecdotal evidence, and women say that changing in their diet certainly helps to manage pain side of symptoms. So they're anti-inflammatory diets or avoiding processed foods, reducing alcohol intake and sugars, and generally a healthy lifestyle. Whether that's just a benefit of a healthier lifestyle that improves their symptoms, it is not clear, or whether it has a direct effect on endometriosis. So there isn't enough research in this area, but a lot of women talk about this, so it's possible. And we do advocate leading a healthy lifestyle with a healthy diet and exercise regime, which is advised both for women who are trying to get pregnant or those who have pain issues.
Brilliant. The next question then is, how long does it take for Solidex to wear off? And when should I expect to ovulate after finishing Solidex treatment and having surgery to remove endometriomas?
So if it's a Zoladex implant, it takes about 3 months to wear off. For some women, they will have a period soon after, or they may even ovulate before they have a period. For others, it can take, depending on for how long Zoladex has been taken. Sometimes there can be a slight delay in return of ovulation and fertility. What was the last bit about how long to wait for?
It says, expect to ovulate again after finishing Solidex and having surgery to remove endometriomas.
So if it depends, if it's short term for up to 6 months, it can come pretty quick within the next month or two. But for some women, it can take longer, especially those who've been on long-term Zoladex or decapeptyl injections.
Brilliant. There's a comment at the end of it as well to say thank you, very informative. And then the next question is, if the progesterone-based treatments doesn't work, there are other alternatives that can help with the symptoms.
Yes, there are. So these are symptoms of pain, I take it, because progestogen, you can't get pregnant while you're taking progestogen. So there are GnRH analogs like Zoladex, which actually are like a pause button on the ovaries. And we know that endometriosis feeds on estrogen secreted by the ovaries. So by giving these injections, we temporarily switch off the ovaries. Because there is no estrogen or progestogen, it causes endometriosis to wither away. But these treatments are only effective for as long as they're taken. A long-term use of these injections, generally injections or implants, can affect the bone density. So we often give some HRT alongside to protect the bones and minimize side effects. They're very effective in management of pain, but it's the side effects that women don't like often.
Thank you. And the next one is, with the immunological impacts you mentioned for achieving and maintaining pregnancy, are there any adverse links to rheumatoid arthritis? And is there anything I can do to improve my chances? I have both RA and endo.
Right. So I'm sorry to hear that. I mean, it is really, both conditions are very difficult to manage and can cause pain. So there are studies which have suggested that other inflammatory conditions could be linked to endometriosis. That includes rheumatoid arthritis, condition known as SLE, and other inflammatory conditions. However, there is no treatment that is directed to manage both of them together. So often women will have different treatments for different conditions. Um, it Rheumatoid arthritis as such should not affect fertility, and even with women with endometriosis, about 80% can have children. It just depends whether they have it naturally or with a little bit of medical help. So I think the key is to seek help early if you're struggling, and then a bespoke package of care can be produced for each woman, because no one treatment is suitable for all.
Brilliant. The next one then is, will a blocked fallopian tube be an issue when collecting eggs for IVF?
Not at all. So the eggs are collected from the ovary, and the tube is actually bypassed in IVF. That's why IVF is often used in women where the tubes are not functioning properly. So that won't cause any issue at all.
Brilliant. The next one then is, what sort of AMH level would you expect to see for stage 4 endo sufferers?
So AMH levels don't always correlate with the stage of the disease or even fertility outcomes. We have kind of moved away from doing them. I think the best response, so obviously they're more affected in women with advanced endometriosis, but we wouldn't use that as a marker, and it can be so variable that I really wouldn't want to put a number on it. It depends on many factors, such as the age. Age is actually a very important factor. So in young women's, you have high levels, and in older women, your AMHs and fertility, egg reserve is affected. So it's not alone to do with grade 4 endometriosis. Also in grade 4 endometriosis, if ovaries are spared, so sometimes we see that bowel is involved, but ovaries are not involved, then the outcome is good. But if the ovaries are involved as well, then the outcome is not as good. But these things can be bypassed. So there isn't a clear answer for most of the things, because you have to take several factors into consideration when planning a fertility treatment.
Thank you. The next one then is, are there any trials still open? I've just been diagnosed with endometriosis by an MRI and I'm waiting surgery. We have one child after laparoscopic treatment in 2015, but have since had 5 failed IVF cycles, lots of eggs, poor quality, and 2 not implanted.
Right, I'm sorry to hear that. So the trials are open, but they are mainly for management of pain. We were looking into a trial of endometrioma, whether surgery is needed or not, but currently infertility trials for endometriosis are not open. But for pain management, there are 3 trials running. For deep endometriosis, it's Diamond, and for recurrence of endometriosis, it's Regal trial, both running from Aberdeen. And for superficial endometriosis, it's Esprit trial, which is running from Edinburgh.
Thank you. The next one then is, how long after stopping the pill should you expect to be able to become fertile again?
So if it's a combined pill, it's almost instantaneous. We even say that if women miss the pill, they can get pregnant. So combined pill is very, very good in those terms. And the moment you stop in your next cycle, your fertility returns to your original level. So that's different for each woman. And the only treatments where there's a delay in return of fertility is generally the Depo-Provera injection, or if you've been using Mirena. So that takes a little bit longer. But with the pill, it is very quick.
Thank you. And the next one is, you mentioned that hormone imbalance with endo can make it difficult to get pregnant. Is this something that is routinely checked by a gynae-assisted conception unit?
So hormonal balance can affect both getting pregnant as well as carrying the pregnancy. However, it is very difficult to check hormonal balance. It is not at the level of the amount of hormone in the blood. It is at the level, what we call cellular level. So actually in the cells from the lining of the womb, or in your pelvis, in the lesions of endometriosis, they exhibit characteristics that they're resistance to progestogen. And so even when the amounts are normal in the blood, the cells are not responding to those normal levels. So it's not the production of hormones. It is about imbalance at local level where pregnancy, where other actions in the cells and endometriosis tissue is happening. So there isn't a test for it. There have been research studies where biopsies have been taken and hormonal effect on the endometriosis lesions have been studied, but there is no such test where we can easily check it by just doing a blood test. It's at a molecular level.
Oh, thank you. Claire, I'm seeing that there's some stuff in the chat, but I can't actually get into it for some reason. Are you able to see what questions are in there?
Yes, I can. Let's have a look. So the next one, when endo isn't, interesting. When endo is an estrogen-led disease, why does taking the combined pill, which includes estrogen, help reduce symptoms?
So the combined pill actually helps by suppressing the ovary and maintaining a homogeneous state of hormone. Combined pill also has progestogen in it. So the way combined pill works, so normally the ovary would produce estrogen first, and only in the second half of the cycle you would have progestogen. Combined pill suppresses the ovary to ovulate and produce the natural amount of hormones, and it's a steady state of hormone with a high dose of progestogen as well. And that's why it causes the endometriosis lesions to stay in a suppressed state. They don't grow because of the combination of the two. If it was estrogen alone, then it would definitely cause growth.
Yeah, okay, that's really helpful. Thanks for the clarification. The next one, I've recently been diagnosed with endometriosis. There's not much info about this that I can find, and I wasn't really informed of what it is, apart from a subform of endometriosis. Are you able to share any knowledge and if it's similar to endometriosis?
That's absolutely right. There's very little information about endosalpingosis. So the difference between endometriosis and endosalpingosis is, in endometriosis, it's cells from the lining of the womb, well, similar to the lining of the womb that are present outside. In endosalpingosis, it's cells similar to the lining of the tube that are present outside. The symptoms are very similar. There's not much research on treatment. So we would still excise them and treat it in similar lines as endometriosis, but there's very little information and very few studies to look at the treatment. So at this point in time, it's treated in the same way as endometriosis. Maybe in the future, we will have more information.
Okay, thank you. The next question, how do people sign up for endometriosis trials? So you mentioned a few in Aberdeen and Edinburgh. How would people get signed up?
So we also advertise these trials via social media through Endometriosis UK, which gives the criteria. Obviously, if you meet the criteria and you are within that region, catchment area, there's a contact detail as well. You can contact the research office if you're interested, and the research nurse might get in touch with you.
Great, thank you. And the last one from the chat is, are ectopic pregnancies still possible with IVF?
Yes, they are. In fact, there's a slightly higher risk of ectopic pregnancies with IVF compared to natural conception, partly because most of the time IVF is done for reasons where there's a tubal blockage or other problems. So that's why women going IVF usually get an early scan at about 6 weeks or so to check the location. It's just the way the embryo might migrate, so it can happen.
Thank you. That's all the questions from the chat. Are there any more in the Q&A, Kirsty?
Thanks, Claire. Yes, we've got one more. Is there anything you can do to improve chances of implantation when trying to conceive, such as diet or supplements?
So we just, at the moment, we just say a healthy diet and exercise regime. We don't have enough evidence to say that a particular vitamin or a particular kind of diet is going to boost fertility. And this is a question women would ask even if they don't have endometriosis. How can I improve my chances of getting pregnancy? But pregnancy depends on so many factors, including genetic, environmental, and not just alone on diet. So I think at the moment the advice is just to have healthy, clean diet, reduce smoking, reduce alcohol, avoid processed food, lots of fruits and veggies, and healthy exercise. Another important aspect is to have a healthy weight. That makes a huge difference in terms of ovulation.
Fantastic. I think that's all the questions at the moment. Does anybody else have anything they want to ask? It's been a very good variation of questions.
Yeah, it has been quite a variety. So, but sometimes there's not a clear answer to everything, because when we treat something, we have to take several factors into account. And it's a combination of duration of fertility, subfertility, age, any other factors, like if there's an associated ovulation problem, tubal problem, or male factor, and that determines how we plan treatment.
I think that's all the questions.
Yeah, that's it from the chat as well.
That's great.
Well, that's been fantastic. There's a comment, I can see it now. For some reason, I can see chat again. Must be gremlins online. It says, thank you so much. This has been incredibly useful. And then there's another one that says, thank you so much for your time. And thank you for all the info.
I think my only advice to women is there is help available, so they shouldn't lose hope. And I think if they're struggling, they should ask to be referred on. And there are a lot of things we can do. So it's not like it is somebody has endometriosis, we can't do anything about it. It's a difficult condition to treat, but there's still help available. So, so that's my only advice. Ask for it if you're struggling.